so much, Sri and John, for the invitation to speak, and MDA for supporting this. I love this talk, and so I'm going to try really hard not to drone on about it, but Dr. Day would throw cookies at me or something to get off. But why I like talking to a group of diverse neuromuscular disease is that it's really about connecting the dots. As a physical therapist, what I'm always trying to learn from is like, what are the other diseases or the variables within diseases that can help us learn about what we're talking about. So today, I'm going to try to take a broad approach to neuromuscular disease. And kind of the roadmap of today is that first I'll talk a little bit about exercise and literature review, trying not to be boring about it, but just getting a few points to drive home about some of the research that's out there. And then primarily, is exercise safe? As long as I've come around talking about, yes, exercise is safe, don't take my word for it. A lot of the literature is really saying that is the case. However, I continue to hear that it's not. So it's confusing and patients are not exercising. For any of us, there's always a way to do it. And I'll show you some of the literature that's showing that. And then in going from the rear view mirror to what we're doing now, of what we're knowing about exercise and what Dr. Day talked about with treatments, where are the gaps in us understanding to help you better dose your exercise? So I'll talk about some of the dosing and ways to measure exercise to see if we can address some of those questions better. And then, of course, I can't leave here without some of the future directions that we're here at Stanford is working on in order to integrate exercise with some of the outcome measures and what it may mean to you in regards to us guiding your clinical care and future research. So as Dr. Day mentioned, advances in treatments really is happening, and it's a really exciting time. But as this time gets really exciting on the medical end, it's also really exciting on the rehab end, because as treatments are becoming available, physical therapists, occupational speech therapists are figuring out how can we complement these treatments in regards to rehab and neurorehabilitation. So why does exercise matter? It really matters because in the gene and cell therapies, as Dr. Day showed, it's not a cure. It's not 100% fixing the problem. So can exercise help with some of the downstream impacts of increasing muscle force, cardiovascular endurance? How do we activate these muscles better? How do we have you move better? And then we also know that responses to treatment are modified by disease modifiers, and that could be different biomarkers, genetics, single nucleotide polymorphisms, sedentary versus an active lifestyle. How can all this contribute so that you can really make the decision that's best for you to really increase your quality of life? And then, of course, exercise impacts mitochondrial, inflammatory pathways, as well as the immune system. With all the AAV therapies, this is really highly impacted, so there has to be some component of exercise that may play a role in this. Some of the basic physiological changes that we know occurs in exercise comes from animal science. When I first wanted to study exercise in neuromuscular disease, I thought, oh, this will be great. I get to see how exercise works on children and adults. And there wasn't any research, so I had to exercise mice. So I'm really happy to say that I don't think I'll have to go back to doing such a thing, but we learn a lot from the mice. And we found that exercise does impact some of these cellular mechanisms. It increases mitochondria, reduces RNA toxicity, as well as improve RNA splicing. That could also impact a lot of the treatments available. And then with this, it also improves muscle metabolomics. So that means your muscles get better oxygen. And that improves the energy balance, the ATP powerhouse that's producing muscle force or energy, the ability for your muscles to contract, as well as what type of muscles, whether it's type 1 or type 2 fibers that help you move. And all of this together really does improve performance, strength, and endurance. And so the lack of exercise also is problematic because it has this really vicious cycle of atrophy and disuse. So if you have a muscle disease that's causing weakness, on top of it you have atrophy and not using your muscle, that may compound your weakness. So how do we help mitigate that by helping you exercise? I like to connect the dots on things. When you don't know a lot about a topic, you look outside of it a little bit. And sarcopenia is a condition that occurs really frequently, and it really is described as, let me see if I can use the pointer, as decrease in lean body mass, increase in fat mass, low physical performance, and low muscle strength. All of you sitting here, as I'm saying that, thinking, that's me, right? And so one study did look at it in all muscular dystrophies, only 14, but they found that all 14 individuals they looked at who had muscular dystrophy was sarcopenic. And we know that sarcopenia contributes to higher disability. And when we're looking at this in regards to sarcopenia, this is studied a lot in aging. And so can we learn from the aging literature, which is huge, on how we can address exercise in dystrophic muscle? And the truth is, we can. What we find that they're in aging muscle, it really responds similar to muscles that are dystrophic or has muscular dystrophy, including how the mitochondrial dysfunction of it and the signal of stress response. So, is exercise safe? So now I'm going to just do a really quick review of some of the literature out there, trying to get a little bit of all the neuromuscular diseases. You'll notice a lot of the studies are small. This study is a 12-week study, and it looked at activities, usually aerobic capacity. And what they found, I want you to concentrate on, is that there was no muscle damage that was seen. Patients had increased physical fitness and improved stamina. So here, this study was done in FSH, but it said that what we were thinking about in the aging literature, deconditioned individuals with FSH do improve with physical fitness. And then, again, driving home the point of exercise being safe, this is a review of 21 studies, and they had strengthening anaerobic exercise, and what they found was there was improvement in strength in 9 of the 11 studies, and in function out of 4 out of 10. We can go into detail why they may not have seen improvement in function, but that's a whole talk about outcomes that's maybe not related to today. But the important thing here is all the exercises show no adverse event, okay? And so then, is it beneficial? Now it's safe, is it beneficial? So some studies are trying to dive into that, and what they found here is that in measuring VO2, that 19% was significant that the exercise group had improvement in aerobic fitness. When looking at function, you can see here they measured by the 6-minute walk test, fatigue severity. They found that that did improve also in this patient population. And so practical takeaways, strengthening can be beneficial. Definitely talk to your physical therapist, your neuromuscular team, because there's different types of strengthening that is safe. It's not an umbrella term that is not safe. It's just how you do it and how you activate your muscles. There wasn't any damage, and long-term exercise should be part of the FSHD care. And this improves quality of life and for an active lifestyle. Now we go to Duchenne, and there's this study called No Use is Disuse. I'm guessing you can guess what the conclusion is. It really is based on cycle training, okay? And what they did is they did training for a group of boys with Duchenne, and what they found was an improvement in function. And as you could see here, the exercise group showed less deterioration of the disease when measuring using the motor function measure compared to the non-exercise group. The other thing we always ask, especially in Duchenne muscular dystrophy, your whole life you're told, do not do strength training. Well, my lovely colleagues at University of Florida is going to try to counter that idea, because in some of the mouse literature, they find that downhill eccentric is damaging, but isometric strengthening actually improves strength. So with this concept, they looked at whether strengthening was safe. And so they did a feasibility study looking at an isometric strengthening program to really determine, basically, is it safe? So this sounds really familiar to you in how you're looking at how you hear about drug studies, right? Is it safe? What's the appropriate dose? And that really is the approach that our community needs to look at to help guide you on what is most practical in implementation of an exercise program. So what they found was, this is a small study, so don't generalize it, but it's really promising, because 7 out of 8 subjects completed the 12-week program, and 7 of them all tolerated it really, really well. The protocol was safe, and it was feasible. They used a machine similar to this that, just like many of the things that we do, is built in someone's garage. So the scaling up part of it may be difficult. But all 7 subjects also showed improvements in strength and function with no adverse events. And so that is really counter to what I've grown up learning about strengthening in Duchenne, so this is really promising. The other thing is to talk about exercise intolerance. We can't pretend that everybody can exercise and tolerate it really well. Some of the attrition that comes out of exercise study is the inability to perform it or the fatigue that it causes. And so what we really need to think about when we're talking about exercise and when you're talking to your clinician is really not only a one-size-fits-all, but the progression of it. So you need to progress slowly to your pace and how you tolerate the exercise. And then lastly, in the literature review, I want to also mention exercise doesn't come without a cognitive or behavioral component, because exercise means that you have to change something that is beyond what you've been normally doing. So this study in myotonic dystrophy looked at exercise plus a cognitive behavioral therapy. And what they found is these sessions help with the initiation of therapy, because we know that any of us initiating exercise is really, really difficult, and then maintaining on the exercise program is hard. So they found that people who participated in the cognitive behavioral therapy sessions had improved sleep, less pain, and increased physical activity, and had a different perception on their change of fatigue. And overall benefits, they found that the patients increase in physical activity and as well as improve in fatigue and their exercise capacity as measured by the 6-minute walk test. Okay, I really like this study because we want to know, like, how can we help our patients by addressing some of the barriers that exist out there regarding exercise. There's a study that looked at in the neuromuscular clinic in Amsterdam. They found that 81% of individuals or clinicians believe that exercise should be a part of the neuromuscular program. However, look at how problematic this is. They don't know how to screen patients appropriately or dose the exercise. Therefore, it's not so much prescribed because they just don't know how to do it. So here you can see here that most of the reason is because of not having the knowledge about prescribing exercise, and then the fear of overwork weakness, okay? While patients, what their most difficult, the difficulty in engaging is their inability to perform these activities. So as we're looking around, how can we adapt it so we can help you be able to perform these? And then the other piece is motivation and fatigue. And I think that goes hand in hand with exercise doesn't happen without a behavior change, right? And so when you're going to clinic and you're going to talk to your neurologist, your physical therapist about getting an exercise program together, what do you have to know? You really should understand what the basic guidelines for physical activities. I'll show you what is out there. But discuss the barriers, because if we can help remove those barriers, you're more likely to be engaged and maintain that exercise program. So physically, what type of exercises are you needing to do? Is it stretching? Is it going to the pool? And it should be at a moderate intensity. What does that all mean? You should sit down with a physical therapist that helps guide that program as you move through it. And then socially, is there difficulty with transportation, assistance to get there, or there are other sports that help with engagement? Because exercise should not be a lonely task. Some of you like to exercise by yourself, but we're more accountable if we have accountability partners, or if we enjoy doing it. Adaptive sports, and there's so many of them in this area. And then cognitively, you saw the research I just showed you, the fear performing the exercise. Ask those questions. Help the clinicians explain things so that maybe that'll alleviate your fear so you can engage in exercise. And of course, giving you the recommendations and resources in your area in order to engage in it. So the basic guidelines are physical activity for people with disabilities is moderate intensity exercise, 30 minutes a day, 5 days a week. I won't call anyone out, but I would say most of us in the room probably don't do this, right? And so if I give this recommendation for any of my patients in the neuromuscular clinic, they're like, yeah, thanks, that's not happening. I have so much going on. So how can we really dose this to make you get up to that level, right? The other thing is also resistance. So strength training, as you heard before, if someone told you this, you're like, oh, that clinician doesn't know anything. I can't do strength training. Like I said, really it's about how you do the strength training. So asking the right questions to ensure that happens. And then the other thing I found was really interesting as I was reading through exercise literature was we always talk about sedentary lifestyle. Well, there's something beyond sedentary. You think that's rock bottom. Well, rock bottom is not that. It's not moving at all. And so what this study found was that a sedentary lifestyle increases your mortality rate. But for a lot of adults with disability, there's beyond sedentary. It is not moving at all. So even getting up out of your chair, not out of your chair, but if you're driving your wheelchair, going shopping, getting out of the house, all of this requires trunk work. It really increases and uses some energy rather than staying at home. And so these are the things that we need to really understand better so that we can promote maybe not an active lifestyle, but go from a non-active lifestyle to a sedentary lifestyle and more towards increased activity. So where are the gaps? We don't know how much. We really don't understand the pathophysiology of exercise in neuromuscular. And if we increase muscle function and we put more strain in the cardiorespiratory system when we exercise, how would that impact your neuromuscular disease? The other one is the impact of muscle metabolism. So if you have more blood circulation, how does that affect the medication that you're taking, the pharmacodynamics or kinematics of drugs? The other one is, of course, really using exercise as a combination therapy to improve health outcomes or slow disease. So as I was looking about the kind of like the drug part of exercise, I always wondered, what can we do with exercise? So I found this mouse study, and keep in mind this is a mouse study. It really looked at low-intensity aerobic exercise before AAV administration. And so they had the mice exercise for 30 minutes prior to the administration of AAV9. And if you could see here, all the blue are the AAV, the treatment plus exercise. You could see they're higher than the green or the black. And basically, to summarize the study, it said that those in the exercise group had improved vector genome uptake, increased transcription levels, and improved mitochondrial function of the heart and the skeletal muscle. So this really could have impact in getting a minimal effective dose in some of the AAV9 treatments. So maybe we should consider what does this look like if we combined it with some of the viral therapy treatments. So what do we need? In order to address some of these gaps, we need to be able to measure this better for safety, and for patients, we need them to have access to exercise in order to perform them independently. So in an exercise program, what should this really look like? It should be a combination of some flexibility, whether that's stretching or passive range of motion, strengthening, like I said, it could be isometric or concentric, high reps or high resistance, low reps, and of course, cardiovascular. And in this, we follow the ACSM, American College Sports and Medicine guidelines, in which they talk about the FIT principles, and that's frequency, intensity, volume, and time. But one of the things we don't talk about enough is progression. In the aging literature, they'd say, why is it that some people don't respond as well to strengthening and aerobic? It's because it's static. So it has to be constantly moving to the next level in which when you're improving. So all of these health components really needs to be personalized to your needs and your goals, taking into consideration your underlying disease, your functional level, and your level of deconditioning, so that could be customized. So then, of course, being the outcome person that I am, if you can't measure it, can we manage it? And my bias is no, so we need to learn how to measure it. So what are the ways that we measure exercise or muscle function? There's activity monitoring, whether you can wear wearables or patient-reported outcomes that talks about how much you exercise. You see us doing this all the time in the clinic, strength testing, motor function tests, and so there's different ways that we can look at your function to see how that impacts. Cardiovascular, which is CPET testing, and I'll talk to you about that in a little bit, because the reason why it's not done so much in neuromuscular is that we can't do it. You can't hop on a treadmill and safely run as hard as you can without fearing that you're going to fall or hurt yourself, or get on an upright bike and bike as hard as you can with not having the appropriate strength or balance. And so we need a way to assess aerobic capacity. And then other like basic muscle physiology, looking at the muscle energetics via MRI, et cetera. So what can you do whenever you're looking at intensity? So this is a lower hanging fruit. When we say moderate intensity, what does that mean? That means that you can easily talk but not sing during an activity. So that's a fairly easy way to monitor that. If, for those of you who like numbers on a scale of 0 to 10, you should feel about a 4 or 6, and that's what's considered moderate intensity. And overall, all of neuromuscular guidelines say that you should exercise at a moderate intensity, whether it's strengthening or cardiovascular. And so going back to the question of if you can't measure it, can you manage it? At Stanford, we wanted to be able to give everybody the opportunity to get an aerobic capacity test. Seemed a lot easier than it is. We finally developed a way to measure aerobic capacity, whether you're in a wheelchair or you're walking. And so this is an assisted bike or a Kaiser training system in order for us to look at what your fitness level is. Because if we know what your fitness level, then we can guide your exercise program a little bit better. You could see that we've done it in quite a few neuromuscular diseases, include SMA, DM, FSH, Pompe, et cetera. And so the other thing that I'm really proud of for us here at Stanford, because I've never been at a place that we can have a referral for neuromuscular testing, or exercise testing, is here at Stanford. Now there's a mechanism. If you want to get aerobic capacity testing, you can get a referral, and then you go to the cardio sports lab, and they will do testing with one of these machines in order for you to get those numbers and results. So with this, what did we do? We wanted, now that we can measure aerobic capacity, we wanted to see what does it look like post-exercise. So what we did here is that we know that post-exercise and recovery is important, because compromised recovery can lead to fatigue, which is a primary variable that many of you experience. Hinder muscle regeneration and recovery, as well as delay on muscle soreness, okay? So then when we looked at this, we want to see how do neuromuscular patients respond compared to controls. We broke the groups out to 2 different groups. We had a small sample size, so we try to put all the dystrophinopathies into group 1, and then other diseases including myotonic, FSH, and SMA in group 2. And you could see here when we compare the differences, in red is the control, in blue are all the neuromuscular patients. And we found that there was a significant difference in many of the recovery metrics, including more reliance on the anaerobic system and ventilatory insufficiency. When we broke out the groups, you can see here red is the control, and then neuromuscular group 1 and neuromuscular group 2, that the VO2 is much higher in the controls. However, what was really cool to us was that this was similar, which is the respiratory quotient, or how hard you can work. This means that no matter who we tested, they all were able to work at their maximum capacity. Despite the fact that there was a clear difference between how hard the controls could work compared to the neuromuscular groups. Also, there were difficulties with eliminating CO2, so the recovery piece of it, where the amount of oxygen and CO2 your body takes in to respond to that recovery, was very different in the neuromuscular group. And we found that group 1, or the more dystrophinopathies, had more of a cardiorespiratory component that hindered that. And so we could see that there's notable changes during recovery, and there are limitations in exercise capacity as well as prolonged recovery. What does that mean? We need to change on how much time you may need between exercise, as well as the intensity of exercise. So really having to monitor that a little bit closer. lastly, I'll talk about how movement is measured. And so we do all this exercise, but at the end of the day, you want to be able to move better. You want to be able to move more efficiently. So we look at time function tests. That's typically what you see, a 10-meter walk, run, and you only have time. So we worked with some of our groups at the bioengineering group and see, can we get more information than that? So when we looked at time function tests, with this open cap system that I'm about to show you, you can quantify how someone moves, how well they move, and different compensations on their range of motion, as well as the strength or the force that comes from their knees or their hips. So here is an example of what we call the timed up and go test. And you can see these two individuals have the exact same time. But it doesn't take a physical therapist to see that they move differently, right? And so if you're in a clinical trial or we're assessing you, we only see the time. And if you improve to have a more efficient walking pattern, we would not know that. And so we did a study over the weekend to look at some of this using a camera system. And so we did 12 different assessments between, that timed up and go, going up the stairs, as well as some of our exploratory outcomes on upper limb. Because if you're in a wheelchair, you're not going to be able to do these. So we want to make sure we include everyone. And then on top of it, we did a patient-reported outcome, which is called the active limb, so that we could see how that responds to how you feel you can do things. And so here's just a video showing a little bit about our day. This is our open cap system in which we measured everyone. All of these they did 12 different activities, and it took maybe 20 minutes. And so in clinic, as long as this takes as long as it takes for you to do the test. And we did this, we just set it up at the gym and able to really successfully get through almost 90 people over the weekend. And then we decided to compare this, not adjusting the algorithm at all to the video or the open capture, but what they already had. And so we looked at, can they discriminate, open cap discriminate better than basic time function test time. And what you could see here is that the accuracy rate is 0.744 for open cap versus 0.488 for the time function test. So just a copy and paste into what open cap has from the bioengineering group, you can also already see that it discriminates better than just basic time. And then so we looked at how does that predict patient-reported outcome measures. So we looked at open cap compared to time function, and open cap was able to predict better. You can see here at 0.43 in the R squared compared to 0.2 with the time function test. So that seems to be pretty good. So we want to integrate this more into our clinic because we want to learn from every patient. So we have more than just time when we see you. So then it moves us on to the last half of it, kind of the future-leaning piece of this talk, is that can we have a personalized approach to how we give you care recommendations from a rehab and exercise perspective? So can we integrate CPET testing, aerobic capacity testing, imaging with MRI, video analysis movement like what you saw, and our clinical evaluation to really give you more this granular information on strengthening cardiovascular as well as bracing or orthotics. So this is really something that I just want to just introduce the idea. So with MRI and kinematic analysis, you really can have determine different how different muscles may be able to respond to exercise and what muscles are more likely to respond, as well as address asymmetries. And then how does this impact what you do, your recommendations in regards to compensations that may increase energy cost or increase risk of injury, and as well as make recommendations for orthotics. So just in the sake of time, I'm just going to quickly breeze through some of the MRI pictures that we have and give you scenarios on how this may work. So we at Stanford, Dr. Day does whole body imaging, and we're able to look at fat infiltration as well as the lean muscle mass in some of these patients and a lot more. But if you look at this here, you can see that there's high fat infiltration in this patient. At the pecs, the rectus abdominis, and so a lot of trunk and proximal weakness, right? And then you could see here there's a lot of asymmetry as well. When you see the smaller muscles are in red and the larger ones are in blue, that there is distinct, clear asymmetries as well as weakness on the left side compared to the right side. So how does this really would impact me as a physical therapist on some of my recommendations? Knowing that there's increased weakness on the left side and they can't get their arm up all the way, indicated by the MRI, I may be able to prescribe something like this where it can assist their arm up. So throughout the entire range, you have individualized amount of support that you may need to get that arm up, so you're strengthening in the whole range of motion, right? And then also knowing that there was trunk weakness, so you saw a lot of abdominal weakness, we may be able to provide more activities that is concentrated towards the muscle groups that are more likely to respond, and do recommend more strengthening or exercises at the pelvis or the trunk. And then, sorry, there's lots of videos here. And then lastly, I want to just talk about the time function test. So here's the same thing. You could see where this patient, there's a lot of muscles that are strong, or the hip muscles, and then the weaker muscles are the ankle, dorsiflexors, etc. And there's asymmetries that exist here. But I want to show you how we can integrate now both of those technologies to help us guide more an individualized approach on how we can manage your care. So this here is showing basically what you would get if you go to a 3D motion analysis lab. And for me, when I look at this, it can show the range of motion and the torque that is at each joint. But also we can see what's different on the left and right side of your body. You can see that this patient is really asymmetric, with the left side being weaker, and that is similar to what you saw in the MRI. And with that being said, the MRI showed that there is fat infiltration mainly at the left ankle dorsiflexors. So what does that mean to me as a physical therapist is that more than likely we can do all the strengthening in the world, but because of the fatty infiltration, they may not be able to improve. So what may I want to do? So I may suggest an AFO or something on the left side, knowing that no matter how hard they work, that's not going to improve, right? But that may improve their ability to walk. I may suggest more strengthening of the hamstrings or the pelvic girdle, focusing on the right side, because the MRI as well as semi-clinical evaluation shows that there's weakness there. So all of that together may be able to give us a holistic picture, utilizing all the technologies we have to give you more individualized approach to exercise. And as Dr. Day said, a lot of what we want to do is to ensure that we engage and advocate for safety and integration of exercise by addressing some of these gaps, but really support clinicians to be able to support you for a active lifestyle throughout the lifespan. And empower you as the patient to talk to whoever you're seeing out there in the community towards an active lifestyle, because it really does take a really holistic approach, and considering the impacts of how exercise really may improve your function as well as your health outcome. And it's not just about medication, but treating your body holistically. And with that, I didn't, it does take a village, and Dr. Day and I did not to touch heads on this. I thank you so much for allowing me to be a part of your village, and of course with Stanford, because without you, we wouldn't have the motivation and the meaningfulness of why we're doing this.